It gives me great pleasure to invite Dr. Samar Basak and for his talk on Lipiview and Lipiflow. And I think we look forward to hearing from him his experience. It is expensive, but is it really worth it in patients? Dr. Basak, please.
Thank you, Dr. Amit, and this is a great honor for me to be here. And this is maybe third or fourth IC we are doing over last few years. So I'll be talking on tear film diagnostic Lipiview and Lipiflow. I do not have any financial interest to disclose. So I'll start with a case. This is an 8-year-old girl. Use of digital devices for more than 8 hours. Recurrent red eye and marginal keratitis in both eyes for 1 year. When asked about her digital screen time, her parents are very reluctant to admit that during COVID time, she used to spend 10 to 12 hours per day online classes and leisure activities on iPad. This habit still she is continuing. We treated her first medically, then we ordered Lipiview. And this is the Lipiview picture of 8 years old girl. So we are shocked to see this kind of meibomian gland. Virtually there is only few gland left. So dry eye and MGD is a global problem. Recently it is more. If you see that the prevalence is between 8.7 to 30%, MGD is in 38 to 68%, more in Asian than Caucasian. So we had studied long time back, about 12 years back, and in our study we showed that MGD is 37%. There are other studies from North India. They have also shown that MGD percentage is quite high, almost 31%. So MGD in cataract population, we know that this is a problem. 52% of patients had MGD and 56 had meibomian gland atrophy. But on the contrary, 50% of the patient of MGD were asymptomatic. This study was in JCRS. And there is a correlation between cataract surgery and dry eye and MGD. So error in biometry, post-op discomfort, worsening of symptoms and anatomical disturbances. So they go in a vicious cycle. So there are many literature along in the and all are recent literature like 2018 onwards. You see that there are studies they have shown that alternation of the meibomian gland expressivity and direct role play in cataract surgery by obstructive mechanism. Tear film LLT significantly goes down. LLT means lipid layer thickness, both during and this is after cataract surgery. So there are also meta-analysis available. So if the patient is having pre-existing MGD, so it gets worsening. This is interesting study in clinical ophthalmology that despite more knowledge and more accessible to treatment, MGD is highly prevalent among ophthalmic healthcare worker, among ophthalmologists and other healthcare provider. The prevalence is 61%. So targeted based therapy on dynamic meibomian gland imaging is effective in improving both objective and subjective measures of MGD. So there is also role with laser refractive surgery, MGD and dry eye. This is a busy chart and there are actually algorithm is there. Then you have ASCRS preoperative OSD algorithm is there. The thing as they always say that the acronym is LLPP, look, lift, pull and push. So you look for the gland opening, lift the lid, pull and evert and also push. So if you have certain gland secretion, then you should be aware that you should not proceed for direct cataract surgery. You treat them, then proceed. So these are the slit lamp. We all know this, that low tear meniscus height, reduced tear length, mucus strand debris, slow or no movement of the debris, then meibomian gland expression. There are different kind of meibomian gland expression. This for the secretion, then toothpaste sign, and sometimes you see interface fringes of MGD's LLT layer. So Lipiview is a system where it implies infrared ray to capture the picture. Then it was also initially called Lipiscan. The current version is Lipiview 2, and Lipiflow is the treatment part. So Lipiview 2, the components are two basic component. One is functional component, the another is structural component. So as I said, interferometry and lipid layer thickness it measure. Blink dynamics it can measure, and infrared mammography with transillumination device, a structural component. So if you see, this is like a oil in water kind of thing. So if we see that, we can always look for this. So normal lipid layer thickness is more than 60 nano. So if you see this machine shows this kind of picture. With a normal blink, you see this, there is beautiful color interferinge pattern, and it moves in a different speed. But in LLT, low LLT, the speed is actually very slow, and the color is like different color. So you can capture these images and show to the patient. This is also how they do the LLT. So LLT, if it's less than 60, then we need to think about lipid layer thickness. It also gives the area of partial blink rate. So I'll show a typical example, and this is the mammography direct, then transillumination, then dual mode for better contrast, and transillumination is available for lower lid only. So if you see this, these are from this gland dropout and dilatation of the drug. So there is a obstruction of the meibomian gland orifices, then there is dilatation, then it may be classified as mild, moderate and severe. Then dropout, you can see that in severe cases there is much dropout. There is no meibomian gland is the lowermost picture. So, but it doesn't, Lipiview doesn't quantify the how much percentage. The other devices, they also quantify it, like how percentage of meibomian gland dropout, like 37%, like 25%, this kind of data they also gives. This is my meibomian gland. It was done in 2018. We had this December. So you see that LLT is just in borderline. I am a totally partial blinker, no complete being 100% partial blinker. C factor means if it is more than 0.9, it means your capture is right. So if you see my gland, the glands are upper lid. If you see both the eyes, it is disturbed. There is no gland pattern. It is tortuous. In some places that it dropped out area, so much dropped out. The lower lid is also similar kind of picture. So apparently we see that we are right, but these are we have checked with our many, we didn't come with any data or any publication. We have checked several. So I had to underwent Lipiflow. I did thrice during last 7 years. So we always think that it should run for 2 years or so. Sometimes we see this kind of gross dropout area, and if you see that the LLT is 52 or 59, capturing is good, partial blink, of course 13 out of 14 blinks. During that eye test, it is 90%, more than 90% partial blinker. So this is another case. You see, though there are dropout area LLT shows, these are false high LLT, because sometimes patient squeezes during the that time some amount of lipid secretion, whatever gland it comes at, it gives erroneous. But look at the anatomy of the meibomian gland, nothing is there. Then this is another example. It matches like 25 average LLT. C factor, capture factor is 100% correct, and both dropout area and so many blocked gland. Is also extensive dropout area. There is no gland in the lower lid. You see, there is no gland. Still the LLT is little higher. So it is again that squeezing, and small little glands are there, few remnants. They actually gave those lipid layer. And this patient asked for multifocal IOL actually. So any case of multifocal IOL in our, or premium IOL, EDOF, anything, we always go for meibomian gland dysfunction, Lipiview, and then we ask, and if it is fine, if it is grossly disturbed like this, there is no question, and whole, because patient overall the tear film stability is not there. It's severe kind of evaporative dry eye. So he or she will never be satisfied with a multifocal IOL. So in pediatric group, is it increasing? So this is my area of interest recently after this COVID. And you know, there are many reports, smartphone and digital devices, they have done many case control study. During the COVID time, we know that online classes and everything. So if you see that power or blink, and we blink less on digital platform. Normally we blink 15 to 20 times, average is 18. You go with the respiratory rate, it is the same as respiratory rate. The cycle, so when we blink less and it is not a complete blink, that means upper lid is not touching the lower lid. And these are vertical gland. Unless it touches the lower lid, there will not be expression of the meibomian gland secretion. So there will be stasis of meibomian gland secretion within the tubular racemose gland. And eventually, this is a kind of disease atrophy. Gradually it becomes dilates, and gradually segment loss and atrophy. This is the thing which is going on with the current situation over last decade. So we see other child, you see this is the 11-year-old child, and you see the meibomian gland, it is horrible. So when this child in our age, what will be his or her meibomian gland like this? We always really worried about this. Then this is another gross dropout, again false high because during the squeezes too much. This is another example, 25, 30, you see the LLT and partial blink. So we have to treat them. There are many methods are available. I have tried in our hospital with demo, and we kept them for 1 month, 2 months, like that. Some methods are good, some methods are bad, but mechanical gland expression in today's era is difficult. Gland probing is difficult. So Lipiflow is one of the system, alternative Lipiflow system, ILUX, and then IPL is there. So IPL is, it acts at a different mechanism. But what I feel that Lipiflow is going good over last 6 years in our hospital. And it is actually, you can actually realize that it helps because it applies temperature between 41 to 43 degrees Celsius, both from the inside and from outside. So it is like, and it is a 12-minute cycle, and it gives pressure maximum 6 psi, and a 12-minute treatment cycle is very much effective. Total time is around 20 minutes to, these are all digital device, so you have to, it is software designed like this. They have come with a different modules now, this activator. So heat from, so there are three components: it thermal pulse therapy, heat from inner aspect, and massaging of the lid. So this is the whole unit. So it also protects the cornea from, there is a vaulted cornea shield is there, the lid warmer is there, and silicone inflation massager. So it acts like this. This is this animation from them. You see, it acts like, really, we call it eye spa, eyelid spa, because you feel that when you do it, that give me more. I mean, treat me more. This kind of sensation. It is so much, I mean, soothing, and no, like in IPL you have to apply so much cream and etc. Sometimes it is difficult to do that, and sometimes it's also burn near the discoloration of the skin we have seen, so we abandon that thing. So there are many studies are there. It really helps. You can go through all the literature. I have read all this literature. It is actually working. So there are different, so before cataract surgery you can, then you do the surgery even after cataract, even for that, for also refractive surgery also. And of course these kids, we are treating these kids, sometimes the applicator size is so much. There are pediatric version is available, but it is not always available in India. So we order, it comes once in a while. That time we treat this with child. And there are like randomized control trial, there are meta-analysis, everything is there. So if you see that this particular article in December 2020, they have suddenly claimed that visible meibomian gland structure increases after vector thermal pulse treatment, that means Lipiflow, in dry eye disease with in MGD. They have shown, if you see that, they have shown the picture on both sides, that they have given several examples, and they have shown that with image software, these glands are pre and post, it is increasing. So I said it is good. So we looked from then our patient. So we do give the treatment and see after 1 year, and you see this is my patient, pre and post. This is captured on 21 September, it's 23 April. If you see the lower lid and upper lid, both the structure has increased. So this is, then on, I make it a habit, the patient when comes for follow-up, 1 year, at 1 year or 1.5 years, you see the glands are actually increased, and the shape of the tubular racemose type of appearance is actually, this is pre-treatment, this is post-treatment. After a gap of say 1.5 years, you see this lower lid, all glands, this is same patient. So I have now, we are on the writing mode of a manuscript. I have now captured almost 29 such patients over last 23, last maybe 1.5 years. And this kind of picture we are getting, and actually these patients are doing fantastic. Now we also, this is not only, we have to tell them that reduce the work on digital platform. We also tell them that see the concept of Johnson baby soap and that stick Johnson and Molish, and then you clean. Those are, you yourself cannot do it. It is not possible. So my saying is, during taking bath, most of us sometimes take hot water, or colder days you can shower on a bath. Create foam around your eye and you just massage. There is no plan like vertical, horizontal. You make it a circular movement like this, so it covers all the thing. And if you do it twice in a day during colder, when you go home, we actually wash our face. That time you do during bath, shower. So hazards of boiling water or sodium bicarbonate, Johnson baby soap, earbud, all this, you cannot do it. So that is, this goes along with it. Along with that, you have to give tear drops which contains lipid. That is, only one thing is available, probably Indian company will come up. So indication is there, so you have to choose the, we have seen in allergic VKC, you can see lot of dry eye disease, patient with glaucoma with mammalian gland. Then if you see that, you always tell that the goal is like this, but you have to carry the other things, and you do not expect immediate results, so you may have to wait 2 to 3 weeks to get the work, and you take the call after 1 year, see again. So basically it is required for both this cataract refractive surgery pre and post, and also for population IT, those IT workers, the children who are on online platform. And pre-procedure and post-procedure, you have to follow up this patient. And it is good if your selection is good, like I showed some of the picture with severe mammalian, no mammalian gland, then it will not act, because there should be some amount of mammalian gland. So it is actually working in most of our cases. You exclude those cases. Thank you very much.
Well, thank you, Dr. Basak. It's always such a pleasure listening to you talk on MGD and Lipiflow. And I think, considering the burden of dry eye and the expense of dry eye in patients, maybe it's not a bad idea if it becomes more affordable for people, just like they go for so many of their treatments and stuff like that, to just get this mechanical expression done at maybe every 10 years, 15 years. It has been shown that if you get one session at an earlier age, the incidence of dry eye in older age may go down significantly. We know it is there. We can't express it. There's no way you can, like you were saying, sir, ki massage, injection. People cannot do it, and cannot do it efficiently. The heat you put with your hanky or a cotton or something does not penetrate enough to melt the meibomian secretion. So I think maybe it should be an everyday booth or something where you can get some expression done, and it helps your.
In our practice, we kept the price very much lower. It is actually supportive to the patient. Cataract is our business. So if you talk about the charges, you know that our charges for Lipiview is only 900. People takes 3,000, I know. And the treatment for Lipiflow is 15,000. So
That
I
is
took Bangalorean IT people
Yes.
that you fly to our hospital,
Yes.
you go for Lipiflow, fly back, still you will gaining more.
Yes.
So it is not for making money.
Correct.
It is making your other patients comfortable.
Right.
There you will do your business. This is our motto. That's why our Lipiview, Lipiflow is going good. Every day we do a lot. Line deke karate hai logon.
Because this machine itself is costing
It
60,
is
70
costly.
lakhs.
It is
So
costly.
you have to take care of the machine cost, plus the activator itself is costing 6,000-7,000 rupees. So that resultant cost is, I think it's a very incredible price in a private center to give.
That's why.
I mean, we do it for 7,500 rupees, but we don't have to pay for the machine. The government buys it for us.
But we have calculated that if the patients are on a queue, your